Good morning, everyone. Thank you for being here for this morning's webinar. We will get started here on time at 10 o'clock here in about 4 minutes. So just want to say thank you to everyone for being here. Please let me know in the chat if you can hear me, and we will get started in just a few minutes. Good morning, everyone. My name is Robert Hersey. Happy Thursday to each of you, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Substance Use in Pregnancy: Fear, Stigma, and Barriers to Care. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to the presenter and myself, the host, FATA Webinars or FATA On Demand, by using the chat panel. The button to open the panel is usually located on the upper right-hand side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. One of these options is on the screen now, and all options are posted in the chat panel as well. After ensuring your volume, both on your computer and your speakers, if applicable, is not lowered, you may click the Communicate menu, then click the Audio Connection panel. Click Disconnect. Repeat the first 2 steps by clicking the Communicate menu and then the Audio Connection panel, and then click Call in using computer and follow the instructions on your screen. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password are on your screen now and in the chat panel. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. We are unable to verify your attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on the training library as shown on your screen. The PDF of today's PowerPoint is also available. If you scroll to the top of the chat box, just a few messages down, you will find a link to the PDF file. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, your web browser will direct you to an evaluation form on the FATA website. You will first need to register or sign into your account to complete the evaluation. Please ensure that your name and email address match the name and email address you provided for your webinar attendance. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation form will close at midnight on Tuesday, October 31st, 2023. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. We encourage you to complete the survey as soon as possible. If you experience technical difficulties accessing the survey, please fill out a contact form at www.fata.org or email training@floridabha.org before the evaluation closes. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Now I would like to introduce our speaker for this morning, Mrs. Kathryn Shea. Kathryn Shea, LCSW, has worked with children with serious emotional and behavioral disorders, including fetal alcohol and drug effects, for over 40 years. Ms. Shea has received numerous awards for her work in infant mental health, fetal alcohol syndrome, and child advocacy. She currently serves on the board of FASD United, formerly NOFAS, and is an independent consultant at the local, state, and national level. Ms. Shea served as the president and CEO of the Florida Center for Early Childhood for 12 years and is a past president of the Florida Association for Infant Mental Health. She received her bachelor's degree in psychology and her master's degree in social work from the University of Kentucky. And now I'd like to welcome our presenter, Mrs. Kathryn Shea. Mrs. Shea, I will turn it over to you.
Thank you, Robert. And Robert said you want a new updated photo, and I'm like, no, that one makes me look so much younger. So I'm sticking with it. Well, good morning, everyone. I see my friend Richard Fay is on. Hi, Richard. It is wonderful to be back here with you. Some of you I've been on with before, and I am delighted to be able to present on this topic today. Many of you know this is a topic that is near and dear to my heart, and I'll talk about that in a little bit. And so let's get started. I hope it's a beautiful Thursday morning wherever you are, because we've just had the most incredible weather, and I'm delighted to be able to be outside and not sweltering in it anymore. So our topic today is substance use in pregnancy, and we're really going to talk about the fear, the stigma, and the barriers to care for pregnant women. And as Robert said, if you have, I hate that I can't see you. I love to train in person. I'm a person people. So not to be able to see your faces or to have conversations is tough, but we will make it work. So if you have any questions or comments, please do use the chat, and Robert and I will make sure that we keep our eye on that. So we are going to get started. Oh, I think I remember I have to. Sometimes this just doesn't want to. Let me see here. There we go. So just to cover our learning objectives for today, we're going to recognize the fears, the stigma, and barriers that pregnant people face in society and identify the most effective treatment approaches available for both during and after the pregnancy. We're going to review the use of some validated screening instruments to better identify substance use in pregnancy. And then we're going to talk about some of the adverse outcomes associated with the most commonly used substances during pregnancy. And for many of you who have been in this field for a long time, this is probably not new information, but it's always important, I think, as we're working in this field to keep being reminded of how special we have to be and how much care we do have to give to pregnant women, because they can really face a lot of barriers and fears and stigma during the time that they are pregnant and after the baby is born. And we want to be as sensitive and as recognizing to women's needs as we can possibly be. Okay, so substance use and substance use disorders in pregnancy are commonly linked with adverse obstetric and neonatal outcomes. All pregnant women should be screened, and those with positive screens should be diagnosed and then offered treatment to avoid the morbidity and mortality associated with continued substance use during pregnancy. And women are often terrified to have that happen, to have the screening happen, and then to have a treatment program offered to them. And we'll talk about what some of the barriers are to that. And substance use during pregnancy and motherhood needs to be a very compassionate and evidence-based solution. And an effort should be made to incorporate women's voices, as they are the authorities on their experience, taking into consideration the whole person and recovery supports and needs. And we still, to this very day in 2023, are so far in a lot of areas of our country from being able to do that, to really listening and to incorporating women's voices in their lives. So we're going to talk about some of the fears and the stigma and barriers pregnant people face. And in one particular study that was done in 2015, there was a fear of detection, and 73% of the women, 73.3, in a study reported that during their pregnancies, they had been afraid of being detected as misusing substances. And the scenarios that they were most afraid of were testing positive for substances at prenatal visits and or after delivery, and the possibility of losing their newborns and their other older children, and experience criminal justice consequences for their substance use. And what we are seeing in opposite to being more caring for pregnant women, there are states that are actually criminalizing this behavior. Women are being jailed for being pregnant. They're being charged with child abuse and neglect, and sometimes more serious charges, because many states are recognizing the fetus as already a child. And I think we all understand that a pregnant woman in jail is not the best situation for the woman, and certainly not for the neonate or the fetus. So there's a lot of fear of incarceration. There's a fear of removal of the child at birth. There's a great deal of fear of being judged as I'm bad, I'm immoral, I'm a criminal in this pregnancy, and using substances, and fear of rejection by our friends and our family and society. And that was a huge one, because we all want our family to be supportive around us. And we see them as our first line of defense. And often that is not the case at all. And then barriers. 66.7% of women in a study had sought substance misuse treatment at some point in the past and encountered multiple barriers to effective and consistent treatment. And so if they've had past experiences with being in treatment programs, they are not likely to seek treatment programs out again. And then some additional fears that have been noted in studies are drug screens, because they don't want to be found that they've been using, anxiety about what to expect during prenatal visits, concerns about Child Protective Services involvement, isolation from oneself and their friends who might detect the substance use, and hiding or denying the pregnancy. And that's the timing of the prenatal appointments, skipping prenatal visits, or avoiding prenatal care altogether, which then puts the fetus at even higher risk because prenatal care is not occurring. And in one particular interview, the interviewer asked the pregnant woman, "Did you do anything to try to hide it or avoid getting caught?" And the woman responded, "Yes, I did. I tried to hide the pregnancy. I denied that I was pregnant. I drank as if I wasn't pregnant, and I denied some more. And then I just kept denying, and I lied a lot." And in another interviewer question, "Did fear of detection stop you from doing anything you might have otherwise wanted to do, like stop you from doing something you wanted because you were worried?" And the respondent said, "Yes, I had stayed isolated. I stopped talking to everyone, period, because I didn't want the wrong person to go over there and say something. I didn't want them to go and do that, and I didn't know who to trust or who not to trust. So I pretty much stayed alone and didn't say anything to anyone." So those are kind of the fears that women experience, which puts them in further isolation rather than getting the support and the help that they need during this time. So the role of the provider is to create this supportive role with no judgment and avoid perpetuating the stigma of the disease for women and families and providers, in seeing this as a healthy experience and supporting women as it being not their fault, but we are there to support them and to make sure this is a healthy experience for them, both emotionally and physically, and to initiate supportive conversations and versus lectures. Women do not need lectures about getting pregnant or how to avoid getting pregnant, and they need support, and their families need to be supportive of them and providers, and we need to reduce the stigma in all of those groups. And to initiate supportive conversations versus lectures on focusing on the importance of prenatal care and more positive birth outcomes. And we can connect women to resources, to screenings. We can go with them if they're afraid, or find a partner to go with them. And then definitely pregnancy support groups, which are pretty much in every community. And often women just need a hand to be able to get there. So some validated screening instruments, and in the years that I've been around, there's been a lot of discussion about which screens are valid and which screens are not. There's also been a lot of research that's been done in this period of time. And currently, 3 separate validated tools exist that screen for the use of one or more substance during pregnant women. And we're just going to look at those rather quickly because I'm sure you probably are familiar with them. So the first one is the 4Ps. That's been around for quite a while, and it was designed to identify drug use in pregnancy and has been validated with pregnant women. And the 4Ps plus is brief, but is associated with a licensing fee, which may be a hindrance to widespread use. There's the assist, which has been validated across several populations, but it has not yet been formally validated with pregnant women. There's the modified assist, with items on tobacco and alcohol use removed, was incorporated by NIDA to their quick screen as a follow-up to the 4-question pre-screener and referred to as the NIDA Quick Screen Assist. There's the SERP-P, is a validated scale composed of 3 questions that can differentiate between populations of pregnant women or low risk or high risk for substance use. And then the SERP-P is a simple and flexible tool for identifying possible substance use in pregnancy. However, further screening is required to identify those who would require treatment. So those are the ones that are being most used at this time. And the 4Ps has been around forever. So what we're going to do now is to move on to some of the general effects of alcohol and drugs on fetal development. And I want to just stop here for a second, because a lot of times when and this goes back to forever when, and I'm dating myself, but when there was a scare of crack cocaine back in the 80s, and then certainly all the fear of cocaine and all of the meth that we've been recently going through. And people tend to think about drugs as the illicit drugs. But we do know that even prescription drugs can have an impact on the fetus, as well as alcohol. And alcohol is by far one of the most damaging drugs to the unborn child. And I have a particular interest in this because, as many of you know, we have an adopted son, Seth, who you'll hear more about Seth as we go along. And we got him as a foster child when he was almost 5 months of age, and we were living in upstate New York. And that was in 1989 when the crack epidemic was taking place in New York City. And there were about 200 babies born a day in the city, and that were either fetal alcohol or crack cocaine affected. And so they ran out of foster homes, they ran out of kinship homes, and a lot of these babies were being housed in DCF offices. And so New York City put out a cry to cities 150 miles within the radius of the city to please open, or if you had foster care programs, to please consider taking one of these babies. So I was a clinical social worker working in upstate New York in Albany at the St. Kathryn Center for Children. And our agency was run by a Catholic nun and we did have a foster care program. And she said, I want every employee to take a foster child. So I'd never seen that on a job responsibility role before. But when the nun spoke, we kind of paid attention. And so I went home and talked to my husband, and I said, and our daughter was 14 at the time. And I said, honey, it's only foster care. You know, it's a short time, and they work to get the babies back to the moms and the families, and all shall be well. Well, 34 years later, we have our Seth, and we ended up being able to adopt him when he was 4, when he was finally freed for adoption. He has full-blown fetal alcohol syndrome. He has every developmental disability accompanied with that. But he is a charmer. He is a gift. He's the best teacher I have ever had. And he will never be able to live independently. He will go into a group home at some point. But I have learned so much from him about what to do and what not to do. So I'll weave some Seth stories in here as we go along. As I said, because I've learned a lot from him. So here's what we do know about the effects of drugs. And remember, when I say drugs, I am talking about alcohol and marijuana as well. We know that they easily cross the placenta and can affect fetal brain development, resulting in lifelong effects on learning, social relationships, employment, and behavior. We do not know exactly how the developmental timing and dosages and genetics affect these processes. But we do know that genetics plays an important role in this, as genetics plays an important role in all fetal development. We know that all substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. And this was discovered by the Institute of Medicine way back in 1996. We do not know specifically how each drug affects specific parts of the brain, although the areas of the brain that appear to be the most impacted by all of the drugs, including alcohol, are those responsible for executive functioning. And we're going to talk a little bit more about executive functioning and how important and how critical that really is if you're going to live an independent, high-functioning life. We do know that in 2020, Morbidity and Mortality Weekly Report article on the Centers of Disease Control, CDC, scientists did find that about 10% of pregnant women reported current alcohol use, and the use of other substances was common among pregnant women, who reported alcohol use at about 40%, reported current use of one or more other substances. And what we do know is that women tend to be polysubstance users, whereas men do not. And so if a woman is using a drug, she is most likely drinking and possibly using other drugs besides just one illicit drug. We know that drugs can alter fetal development through a wide variety of mechanisms, and actually also directly impact the uterus and or the placenta and the heart and the lungs and the brain of the mother. So when we talk about drugs, we have to remember that prescription drugs, which are legally prescribed by a doctor and used as directed by a healthcare professional, and all healthcare professionals should be aware of prescription meds in the developing fetus. Those non-prescription meds are over-the-counter drugs that can be purchased at a grocery store and drugstores that also can have an effect on the unborn child. And this is a slide that might be difficult to see, but this is just a slide of fetal development. And one of the most critical times in fetal development for the brain to be impacted, actually, if you look at that top line, that is the brain. And you can see that the brain can be impacted at any point during the pregnancy. And the first 3 months are the most critical. And that is usually the period of time where the woman doesn't even know that she's pregnant. And sometimes women don't know until they're like 14, 15, 16 weeks pregnant. Well, if there's been, moderate to high use of alcohol or drugs during this period of time, there is a high percentage, there's a good percentage that there's going to be an impact on the brain. And as you go down that line, you can see the dark blue is the period of time where critical impact can occur, and the lighter blue where lesser impact can occur. But you can see that almost no organ is left out of this system, and that all organs can be impacted at various points in the development of the fetus. And it depends on dosage, with what part in fetal development is it occurring, and how long, what period is it, how long is that period of using occurring and taking place. So all of those roles, all of those things play a factor in the outcome for the fetus. So we're going to talk about a teratogen, because a teratogen is typically sometimes referred to as a poison or toxic substance, and it's an agent that can cause physical or developmental defects in the unborn child. The most common teratogens are alcohol, mercury, a treatment for severe acne, Accutane. Nicotine is a teratogen. And then phendotoin, Dilantin, which is a treatment for epilepsy. And we know that there is a high usage of alcohol and nicotine together. So if a woman is drinking and smoking, she has two teratogens going into her system simultaneously that can significantly impact the outcome on the fetus. We do know that combining substances, the greater amount of the drugs and the longer the duration and the frequency used, the greater the risk to the unborn child. And the risks are significantly higher when mothers have used a combination of drugs during pregnancy, and a combination of smoking and drinking alcohol during pregnancy adds additionally high risk, because as we just talked about, those are two teratogenic agents that are being used in combination. So who's the most at risk? There's a lot of research that's continuing to be done by CDC and other organizations, but most recent research is showing that the age groups of 18 to 34 with the highest birth rates are also the age groups most likely to use legal and illegal substances. Binge drinking, which is doesn't seem like that would be as big a deal, but binge drinking can be very dangerous for the developing brain. And the highest risk group for binge drinking is women. This is so interesting, is women in their 30s with a college degree earning more than $50,000 a year. So this is the sort of social drinking women's club. And if you talk to women in this age group, and when my daughter was in this age group, she would say, Mom, the doctors would say a drink or two, isn't going to hurt anything. And not really talking about the effects of alcohol or smoking during this time. But that is a sophisticated group of women that are binge drinking during this period of time. And the reason that binge drinking is so dangerous is because binge drinking is considered 5 drinks or more at a time. Well, the more a woman drinks, the higher the alcohol level in her blood. And the alcohol level in her blood is equal to the alcohol level in the fetus. So the fetus is actually becoming intoxicated as the mother is becoming intoxicated. And what we now know is that there is no safe amount of alcohol or drugs. There is no safe amount of time. There's no safe time during the period of fetal development for substances to be used. Some of the risk factors: the dose of alcohol and drugs, the timing of the moderate or high use during pregnancy, the pattern of exposure, binge versus chronic, developmental timing of exposure, the genetic variation. We know that every mother has her own genetic makeup, and we also know that every fetus has their own genetic makeup. And we know this through twin studies, where one twin may be dramatically affected and the other twin more mildly so. So the fetus's genetic makeup also has an important factor in some of the risk factors. maternal characteristics, the health of the mother, both mentally and physically, some of the synergistic reactions with other drugs, and then interaction with nutritional variables. We know that women who have poor nutrition in pregnancy that are also using drugs put the risk factors at a much higher level. So how do drugs and alcohol reach a fetus? We used to think that that placenta was a barrier and that would protect the fetus from anything toxic or anything poison or any kind of drug or anything that would be bad for the fetus. And we now know that that is not true. A pregnant person who uses a drug or alcohol, it readily moves across the placenta into the fetus's bloodstream through the umbilical cord. And as I said before, when the mother is drinking, the alcohol level of the mother is equal to the alcohol level in the fetus. So the use of drugs and alcohol increases risk for mothers and fetus. A pregnant person's use of alcohol and drugs can increase the risk for prenatal death, for premature birth, definitely for miscarriage, birth defects, low birth weight, small size for gestational age, neurobehavioral symptoms, a smaller head circumference, and a faster than normal heart rate. And we'll go into the specifics of those in just a bit. So the effect of alcohol on the brain, and I'm going to talk about alcohol because it is the most significant of all the other drugs combined for the impact on brain development, but the entire system. So as a fetus develops, the cells that will become the brain and nervous system attach to each other, as you can see in the picture here. The alcohol interferes with this process of brain development. And again, whatever part of the brain is developing at that particular point in time, in that developmental phase, is what is going to be impacted. And then the baby's brain may be smaller, structurally or functionally damaged with right and left hemisphere abnormalities. And this is the brain on the left, was obtained from a 5-day-old child that was stillborn and was exposed to alcohol prenatally at a pretty significant level. And then the brain on the right is the brain of a normal newborn, full term, that was not exposed, that was stillbirth, but was not exposed to any alcohol at all. This is one of the very first pictures of the structural damage that can occur to the baby's brain prenatally. And as you can see, there's a difference in head size. There's a difference in the structural formation of the brain. That really rich, almost sort of spaghetti-like top of that brain, that corpus callosum, you can see is significantly impacted on the baby that's been prenatally exposed to alcohol. And the interesting thing is, there were studies done on animals long before we had these kinds of MRIs from humans. And it started way back in the 30s with mice and then guinea pigs. And if you don't have anything else to do and you're curious about this, you can go back and do some research. There was a research study done by a Dr. Stoddard in the 30s with guinea pigs. And he had a control group of guinea pigs that were not exposed to any alcohol whatsoever, and then a group of guinea pigs that were exposed to what would be equal to 1 or 2 drinks per day. When the babies were born, they're called pups. When the pups were born, the exposed pups had every single feature that we see in human beings with fetal alcohol syndrome. The abnormal cranial facial features, small brains, poor motor coordination, poor memory in maze trails. And the pups that were not exposed were perfectly normally developed and functional in every way. The interesting thing about this study that has never been repeated to my knowledge is that Dr. Stoddard followed this exposed group for 4 generations without ever having another generation directly exposed to alcohol, and 4 generations later, there were still cognitive delays and a smaller head size in those pups. So if you think about how does in every animal study, the facial features and the the motor coordination aspects have completely followed, regardless of the animal. So if you think about the fact that if possibly in humans, 4 generations after the initial prenatal alcohol exposure, we could still be seeing some brain changes or cell changes. I think that's pretty mind-blowing. Just a tidbit of information. So the impact of prenatal fetal exposure to drugs and alcohol, it does appear that all or nearly all of the drugs impacting the developing brain cause neurobehavioral effects in the fetus that can be lifelong. The effects can be physical, emotional, cognitive, social, and behavioral, and usually are a combination of all of the above. Opioids and polysubstance exposure research shows behavior and attention problems in lower cognitive functioning in 8-year-old children. And what we are seeing is that some of the substances like cocaine in particular are having much more of an effect with having more like ADHD symptoms rather than the sort of significant long-term brain development or brain impact that we're seeing in some of the other drugs. So we're going to pause here for just a second and just take in what we've talked about so far. And if you have any comments or questions, please post those in the chat and we will take those. And if any of you had sort of that aha moment of you learned something or heard something you didn't know, share that as well.
Shea, I have a question in the chat from an individual who asked about the effects of people smoking nicotine around the pregnant woman, if that affects the fetus as well or just the pregnant mother.
Well, that's a really good question because there are some studies of secondhand smoke for sure, and I think that some are saying yes, there are effects, and some are saying no. I would say don't take a chance, and that baby is inhaling that smoke, and that can definitely, I would think, could definitely have an impact on the brain, certainly on maybe even on the lungs.
Thank you. And then a follow-up question I'm just seeing from the same individual. Same with the effects of people smoking, say, crack or other substances around pregnant women. Does that affect the fetus?
I would say absolutely yes, because again, that fetus is inhaling or taking in those toxic fumes, if you will, around them. And I would think it would be impacting their lungs for sure. Actually, there was a study where babies got high from the effects of their parents smoking pot. So yes, I would say that any drug that's smoked or used, that the effects can impact the fetus or the baby. And I did see that a couple of people noted that the audio is poor. I don't know what to do about that. And I'm having a hard time reading that chat, Robert.
Sure. There are a lot of people that are saying the aha moment for them was the generational effect of alcohol on brain development. So it seems like a lot of people agree that that was an aha moment, as well as the effect of alcohol being more than drugs. So it seems like there's a lot just from that last slide about the generational effects on genetic variations. There is one other question that I'm seeing. Person asked how much secondhand exposure would it take to cause damage? Is there any research about that?
I have not seen any research on secondhand impact. I will look at that, but I have not seen I've not seen anything on that, but that's a really good question. And I think, you know, the CDC's information about don't take chances. And I think that is both, you know, don't take any risk whatsoever. And so if you're in a group where there's people are smoking or using pot or smoking crack or meth, don't put your baby in that environment. Why take any risk, you know, for that to happen? And I'm seeing, Robert, some people are saying their audio is good and some are not, so I don't know that we can do anything about that. Oh, and I did just see one about the father's drug use. There are some reported studies that with alcohol in particular, there is a higher incidence of behavioral disorders in children with alcohol, with substance use in the alcohol. Oh, hi, Cecily. But I don't know that that has been confirmed. I think there's some studies that are suggesting that. And I also just want to say about the generational, multi-generational use, that was not with humans. That was, and I've only seen one study, and I've tried to follow this up to see if any more have been repeated. And I don't know why more haven't been repeated, because I think it's so important. That was a study done in the 30s with guinea pigs. So I don't know that we can equate that to humans, but since every other animal study has equated pretty much to what we see in humans with prenatal alcohol exposure, I would, you know, my assumption, I would say it's a caution. Anything else that you see there, Robert, that I've missed?
I think one question, and maybe perhaps a final question for this. Well, I guess there's two that I've seen that are pretty major questions. So I'll ask them at the same time, and this can be kind of the final two questions. Somebody asked specifically when it comes to fathers if there's any use on substance misuse when if it affects the sperm of the father. And then another question, kind of a different topic, is does alcohol affect any other body parts? So are there any physical deformities that can come as a result of alcohol use?
Great questions. Yes, there are some studies that indicate that there are sperm defects in the fathers who are chronic alcoholics. And I don't know if I have that listed in references, but whoever asked that question, if you can, my contact information is on the last slide. You can email me and I will run that study down for you and send it to you. And then in terms of alcohol and the impact on other body parts, there is not a system in the body that is not affected by alcohol. It can cause significant birth defects. Seth was born with a cleft palate. And what happens is alcohol in particular is a drug that affects the brain and runs all the way down the midline. And the midline is from the top of your brain all the way down. So there can be significant defects from the brain to the eyes. The midface can definitely be affected. I didn't put those slides in here, but craniofacial features are there. The cleft can be affected, significant heart defects, gastrointestinal, kidney, all the way down to genital defects in both boys and girls. So yes, depending on the amount of the alcohol, the usage of the alcohol, physical defects and abnormalities can absolutely be there. Good questions. Okay, I think if we're good, and if you haven't been able to ask a question during this webinar, or if I have not answered your question sufficiently, please email me and I will dig deeper for information to make sure that you've got what you need and your questions are answered sufficiently. So I think we're good to move on, Robert?
Yes.
Okay. So what do we see in the newborns? And this was a question we started to get at. So depending on the amount, again, it's a it's a dose usage phenomenon. The more drugs or alcohol that's used throughout the pregnancy at those significant periods of time when fetal development is occurring, that's when we're going to see the significance from mild reactions to very significant reactions. So withdrawal from substance-exposed newborns can be very physically distressing. If you've ever been in a NICU and you've seen some of this withdrawal, it's really hard not to be emotionally impacted by it. And they can demonstrate several typical signs of withdrawal from mild to severe. Tremors are almost always present. And Seth is 34 and still has tremors. Tremors has been a significant neurological defect for him from the very beginning. Sleeplessness, there are more and more studies coming out now that those affected with alcohol in particular never develop that sleep-wake cycle. So being able, and this is so true of so many women that I've talked to that are mothers, adopted mothers, birth mothers, that their kiddos never really develop a great sleep pattern. This high-pitched crying and agitation, and if you've never heard that high-pitched crying, it takes a long time for it to leave your ears. Muscle spasms can be there, seizures can be there, and all kinds of feeding difficulties. Seth, because he had a cleft palate of the soft palate, but he also had very poor suck reflux because of the motor, the impact on the tone, the motor tone. It would take 2 hours to feed him 2 ounces of formula, and then he would regurgitate it. So those feeding difficulties, if you're a new mom and you've never been through this before, I mean, even babies without issues can be really challenging. But if you've got a baby who's taking 2 hours to eat and then is losing all of it and you're starting all over again from scratch, just think about how frustrating that might be to a new mom who's either, trying to withdraw from substances or still using herself. That can be really, really hard and challenging. So a lot of people have asked about should women breastfeed or not breastfeed when on medication-assisted treatment. And what we do know is the baby receives all the benefits of breast milk, and there are a billion studies probably today about the benefits of breast milk. It does enhance maternal-infant bonding. It is safe to breast or chest feed while taking medications for opioid use, such as methadone, regardless of the dose of the medication that you take. In the consult with LACMed database to learn more about the evidence on the use of medications while lactating, such as methadone and buprenorphine and naloxone. So there was forever this thing that if you're taking medication, if you're on medication-assisted treatment, you can't breastfeed. So we know that that is not true, but it does need to be followed, and you need to have a close conversation with your doctor. Breast or chest feeding can make the baby's withdrawal symptoms less severe, and certainly there are studies that suggest that skin-to-skin contact and attachment formation really do help to feel the baby to feel better. That skin-to-skin contact is so important in attachment. And when other opioids like methadone were studied, it was found that only about 2% of the total dose made it into the human milk. And for buprenorphine, there's negligible amounts that are found in the human milk. And infants absorb even less of this because of how it is broken down and metabolized, not absorbed well in the stomach. So don't automatically think that if a woman is on medication-assisted treatment that she can't breastfeed. She can. So the cautions of breastfeeding when using illicit substances: with heroin and other unregulated opioids, it is best not to breast or chest feed, since you don't know the exact dose, and it may be cut with other unknown substances and contaminants that aren't safe for the baby. there was an incident probably a couple of months ago in, I think it was in St. Pete, where an infant was taken to the emergency room, and the mom had breastfed just a couple of hours before that, and there was actually fentanyl found in the baby's system. The baby survived, but if the mom is using fentanyl cut with hair, and we all know that there's a lot of heroin that's being cut with fentanyl, that could be actually lethal for the baby. And most drugs a mother takes are present in her breast milk in small amounts. And the safety risk for an infant when the mother is falling asleep. And that's the other issue. We when I was at the Florida Center, we have a Healthy Families program. And so that's a program that's working with pregnant moms as well as shortly after their babies are born and can stay there for 5 years. But one of the reports from our Healthy Families worker, even with the moms that were like on methadone, it wasn't the methadone that was causing the problem. They would go into the home and the baby would be asleep under the mom or next to the mom because she was so drowsy and falling asleep. So making sure that the baby is safe and mom's following the safety rules about sleep with the infant is also something to be really, really cautious of and pay attention to.
Ms. Shea, may I ask a quick question in the chat on that topic? An
Sure.
individual asks, what about moms with medical marijuana who desire to breastfeed? Should this be viewed the same as MAT?
That is a really good question, and I'm not a physician and I really don't know the answer. We do know that marijuana goes into the breast milk. I think that would be a conversation to have with a physician to really talk about the benefits versus the risk. And I'm not well versed on that. So if it's prescribed marijuana for a particular reason, usually that's for anxiety or PTSD kind of related conditions. There might be other safer medications to be able to be used, but I would say that would need to be a conversation to be held between the woman and her doctor. I hope that helped. Okay, some of the short and long-term developmental prenatal exposure to alcohol and drugs. Again, it's the areas of the brain that are most impacted by alcohol negatively, and that is going to affect what we call executive functioning. And I'm so big on this because you can't live in this world without executive functioning. And it is the last developing part of the brain. The brain develops from the front to the back and from the bottom to the top. And so your executive functioning is way up here in the front of your brain. And it's your ability to focus and to concentrate on a task. It gives you that cognitive flexibility of being able to change priorities or make different decisions in the moment if one isn't working. That thinking outside of the box kind of thinking. You have working memory, which is holding information in your mind, and that's in your hippocampus, and working with it, doing mental arithmetic or understanding a story. One of the most important is inhibitory control, and that's that ability to go off your autopilot and to do what is appropriate, even though you want to do something else, to be able to control your inhibitions. And the areas of the brain involved in executive functionings include that prefrontal cortex, and it works in concert with other parts of the brain, including the parietal cortex and the hippocampus. The executive functions are a set of processes that involve managing oneself and one's resources to achieve a goal, and it's an umbrella term for the neurologically based skills involving mental control and self-regulation. And what I have found in my years of being involved in this work is that this is absolutely the area that is most impacted with prenatal alcohol exposure. And again, if you're using multiple drugs in unison, you're increasing the risk for this. And what we have here are layers of self-regulation. And what we what we can see in many of the drugs is dysregulation in a lot of these areas. And that very bottom basic level of self-regulation is our basic physiological regulation. And that's our feeding regulation, that we feel hungry when we need to eat, our sleep-wake regulation, our heart rate, our breathing rate, all of those things that keep us alive. And I mentioned before that in some of those basic physiological regulations, kids with fetal alcohol in particular don't have that sleep-wake cycle. There are kids that I've worked with that don't know when they're hungry, and so they're not good eaters, or they don't know when to stop eating, and they tend to be able to then become obese. But certainly the ability to pay attention. We see that with crack, cocaine, even marijuana, and certainly with fetal alcohol. That emotional regulation you can see kind of throughout, but that's just the inability to regulate your emotional state. That's in your amygdala part of your brain. And if you can't regulate your emotions, you're going to have difficulty regulating your behaviors. So these are kiddos that are always going to be in trouble, which then leads to negative self-esteem or into trouble in some other kind of way. And these are kids at higher risk of being expelled from preschool, if you can believe it. Certainly school have higher instances of being expelled or suspended. They are bullied kids because they're different. They have a tendency to be more trouble with the law, to end up homeless, to end up in prison, because they do not have adequate executive functioning. And I don't know if all of you know this, but the Parkland shooter, and I'm blocking on his name, but somebody, oh, I just went blank on his name. But anyway, I don't know if you all know that, yes, thank you, Nicholas Cruz. He was found during the course of the trial from some astute attorney, because we did a lot of training over on that side of the coast, and an attorney suspected fetal alcohol. And so the National Organization on Fetal Alcohol Syndrome has a legal team, and they went into the jail and they evaluated him and found out he was full-blown fetal alcohol syndrome. And when they put his story together, he had been adopted. His mother had used alcohol and other substances. He was in and out of foster care, I think once or twice, and then adopted. Major problems in preschool. He was diagnosed with a developmental disability at the age of 3. In a very poor school, in and out of school, bullied in school. His father died, which was a major trauma to him. And then it was 6 months after his mother died that he committed the Parkland shootings. And because of testimony by these experts in FASD, I think it was only by 2 votes of the jurors that he was given life in prison versus execution. And so finding these kiddos early and intervening early is so critically important, because it actually, I mean, it saved his life. And people say to me, well, you know, what's better, being executed or having life in prison? I don't know the answer to that, but I would certainly choose life in prison. But it was only because 2 jurors, one of who I just met yesterday, looked at this in the reality and the course that it was and said this was brain damage to a very tormented, tortured individual that caused this to happen. This is atypical. I mean, this is sort of the outlier scenario that you would see, but I have to wonder how many of those kiddos are out there that we're not reaching because we just don't know that this exists. And I want us all to get better at finding them, identifying them, seeing them, getting them evaluated, and then being their advocates. Okay. And this is just a brain. I'm a visual person of your executive functioning. That frontal lobe that you see up there is that important lobe that we're talking about. Again, it's the last part of the brain to be developed, but it's definitely the one that we need the most in order to help us do all of those functions. Because Seth's executive functioning is so poor, he will not be able to live independently. But the amazing thing is, what we have learned is that it never stops developing. And I was always taught, at a certain point in time, your development plateaus, your brain plateaus, you can't get past a certain point. Believe me, folks, that is not true. Don't ever say they stop developing, because he amazes us every single day. It's almost like you can see the connectors connecting and forming in his brain. He's incredibly humorous, which takes up, that takes a bit of executive functioning. He can be a pre-planner, and he's always saying, "Mom, what's the plan?" Now, plan is an executive function, and then he now can kind of lay out the steps to what the plan might be, and then we kind of review and say, how would you do that differently? So you can teach executive functioning skills. I am working with our early Head Start program here in Sarasota now, and I am actually teaching the teachers on how to teach executive functioning skills to the kids in preschool. And I love it. It's so exciting to see a little 2-year-old say, I want to make a plan. So we can't, normally this is just normal brain development. If everything were in our brains were not injured or hurt, and our environmental experiences were good and sound and we were taken care of, this would be normal brain development. But for these kiddos that have had impacts of drugs and alcohol, and then sometimes very poor environments, so on an additional layer, maybe abuse and neglect and PTSD. But if we can reach them early and begin to teach these kinds of skills, we can help them move along to their highest developmental potential. So when should a parent or a caregiver, neuroplasticity, thank you, Giovanna, yes. Neuroplasticity we know is great in the first 5 years of life. I am a believer that it never stops, and that we just keep plugging along, and we see that brain is always ever changing and growing. And sometimes Seth will come out with the most profound things. It's like, where did that come from? So don't ever give up. Seth says, never say never. And thank you for that, neuroplasticity. So a parent or a caregiver, yes, same here. Neurons keep on growing. Yes, they do. And isn't that a wonderful thing when you get to be my age? It's a wonderful thing. Keep that brain alive. So a parent or a caregiver should seek help. What should be going on in our systems is that if children are in foster care, and over 70% of these children with alcohol exposure, and many with drug exposures, and as I said, it's usually multiple drugs that have the child has been exposed to. We want, if they are in child welfare, they should be getting an early steps evaluation. And but often, well, I won't say often, but a lot of times because the eligibility level for early steps has changed, they aren't qualifying for services in those first 3 years. And often the symptoms that we see are not presenting until the child is in school. So we can't lose track of them. If they really need to be evaluated or screened annually for developmental success or progress or problems. So if they're demonstrating behaviors that are atypical for a stage of development, we want them screened. If the caregiver is worried about their behaviors and there's something that says to the mom or the caregiver, there's just something not right here. When the caregiver needs reassurance that their infant or child is meeting developmental milestones, your pediatrician should be your first go-to. And yet I'm so discouraged about pediatricians' awareness of FAS, not just in the state of Florida, but in general. They'll look for the facial features of FAS. Less than 10% of kids prenatally exposed to alcohol have the facial features, but they're on the FASD spectrum. And if you're not getting an answer there, I mean, if you feel like something is wrong and your pediatrician is saying, I don't see anything wrong, they're pretty much, on their developmental track, or they might have a little delay here or there, go see a developmental pediatrician. They're much more skilled at kind of knowing where that development is. And making sure the pediatrician is aware of the prenatal, the birth, and the neonatal history, because that can really give them a great deal of information. And the earlier that we can identify and intervene, we can significantly improve the long-term outcomes for these children. That's why I am such an early childhood person and early interventionist, because it makes all the difference in the world for the parents and for the kiddos. So the impact of substance use on infant and parent relationship, we know that moms with behavioral needs and behavioral health needs, and maybe those that are still using or having a really hard time in getting clean and staying clean, which is so hard if you are dealing with a newborn that is in withdrawal or have compromised brains. That's almost a setup for failure. They've got to have supports. They have to have people who are walking the walk with them and not being judgmental, but being supportive and caring and nurturing. That is just so important. And how substance use affects the mother, and I'm going to say mother-infant attachment. That's not leaving dads out. Dads are very much a part of the attachment process for the infant as well. And if they're in the picture or not in the picture, or only partially in the picture, they need to be considered as a part of this attachment process. And so addiction is associated with a dysregulation of the balance between reward and stress, neurobiological systems, which can undergo significant changes during the transition to parenthood. Drug use can affect these neurocircuits and what we call hijack some of that same reward processing systems in the brain, making moms less responsive to more natural reward cues, such as their infant's behaviors and their facial expressions, that can be sort of numbed in the mothers and in the fathers, where they're not getting that natural reward of the baby's cueing or smiling as that feedback to the parent of that attachment process being a positive one. And if the mother or the father did not have secure attachment with a primary caregiver, and that is frequently the case, as a child, they don't have a modeling. They don't have that internal working model to create that for the baby. There's nothing that they can draw from. In their experience, it says, this is how I should be relating to my baby, or holding my baby, or looking at my baby, or communicating with my baby in this cycle. And so thus we tend to see this cycle repeating itself over and over. And I am so all about breaking this cycle of drug abuse and neglect, and child abuse and neglect, and mental health issues. And I often say to the teachers at Head Start and Early Head Start, if you can change the trajectory for just one child that you are working with in their family, you have changed the trajectory for generations to come in that person's world. Think about the impact of that and the power that can be. You can be the one person to change the entire generations for generations to come and help break this cycle of failure and sadness. And nearly all drugs affected the neurobehavioral systems of the baby's brains, sometimes for a lifetime. This is the baby's part. Many of the infants exhibit symptoms of a regulatory disorder, which can include dysfunction in that automatic regulation we talked about, sleep-wake cycles, motor control, attention, interaction, and self-regulatory systems. And dysregulation in any one or more of these domains may interfere with basic neonatal functions, such as feeding, which we talked about, sleeping, growth, emotional regulation, attachment, and or social interaction. And there was this great study that was done by Anne Streisguth. I think it's in your list of resources. And it was done a long time ago, but she was the guru from the University of Washington in Seattle. She was involved in the diagnostic team that first diagnosed the first, I think it was 5 babies with fetal alcohol syndrome in a NICU in Seattle, Washington. And she followed over 100 of them throughout their childhood. And she wrote what's called her secondary disability studies and found that there were so many outcomes that were related to this prenatal alcohol. And she called them secondary disabilities because she said the impact of environment had this play on them. I am convinced they are primary disabilities, that it was because of the brain damage itself that so many of these things occurred. And we now know that regardless of the environment the baby is living in, whether they're with the birth family, certainly it can be much worse if there's domestic violence going on in the birth family or continued substance use. But so many of these babies that were like Seth, that were adopted shortly after birth and never lived in a chaotic or turmoil, still have all of the similar issues that we see in the secondary disability study. And she found that 90% of them would have a mental health diagnosis by the age of 5. And usually that first mental health diagnosis was ADHD because they were so impulsive and so hyperactive. And then it went on to go to mood disorders, disruptive behavior disorders, obsessive compulsive disorders, bipolar disorder, suicide, depression, high levels of anxiety, trouble with the law, all that whole gamut of how these kiddos can progress. And I've just had the recent experience in one of the things I do for Children First, the Head Start, Early Head Start program, is work with staff who are going through a lot of stress and just need some support, who are feeling anxious, either personally or professionally in their lives. And I got hooked up with a staff person a year ago. She was the adoptive mother of a 19-year-old who had been exposed to alcohol and drugs in utero. He had gone back to the birth mom 3 times and then ended back up as her adopted son at the age of 2.5. So think about that early disruption. All kinds of trouble in school, was bullied in school, and the best caring parents in the whole wide world. And 2 years ago, at the age of 19, out of nowhere, he was arrested on 3 counts of aggravated sexual assault. And the sexual assault was sex texting. And I don't even know what that is. But for those of you who are more sophisticated with Snapchat and Instagram and all those kinds of things, he had hooked up with a 13-year-old girl on there. And he was 19 at the time. And they were sex texting back and forth, sharing photographs, nude photographs. And her brother found out and reported him. 1 year later, he was arrested. His mom was so distraught that she got a hold of me and said, I don't know what I'm going to do. I had no idea this was going on. I'm supposed to be the good mom and protect him. And so I started working with her a year ago and with him, not therapy, but just support and meeting with him. And I knew by the 3rd meeting with him that he was on FASD. and sent him to the Florida Center, where he was absolutely diagnosed with an FASD. We sent him for a forensic eval, and he had the highest verbal skills ever, and no real physical features, although he was hospitalized for failure to thrive when he was 2 years of age. And but in talking with him, he could tell you, he could talk to you, but he had no concept of what was really taking place. He had no impulse control. He was still living at home with mom, and he just turned 22, and so no understanding of that cause effect. And when I said, and I won't say his name, but did you understand when you were sending these photos that that was not a good thing to do, that could possibly be a violation of the law because you were 19 and she was 13? And he said, no, I thought she was like 17 or 18. And I said, did you ask her? And he's like, no, I just thought she was 17 or 18. That kind of cognitive breakdown can get them into so much trouble. So this young man was going to be sentenced to 3 to 20 years in a federal prison, 3 to 20 years for 2 weeks of sex texting. And so I got involved, of course, as an advocate, and I testified in court. This was about 6 or 7 weeks ago. The forensic doctor testified, and because of our testimony, he was sentenced to 7 months in jail, county jail. And he's now in our recovery pod. He's getting treatment all day long. He is doing so incredibly well, and they're working with job sources for him for when he gets out. But that's the difference that one advocate can make in these individual lives, and there are thousands of them that are not being found and being attended to. So this lack of impulse control and this lack of cause and effect for him were two serious cognitive deficits that could have, landed him in jail for 20 years. So yeah, I just got on a soapbox, but it just breaks my heart when I see these things happen, and I just know there's so much more we could be doing, and we will. And you're all now officially FASD advocates, whether you want to be or not, and advocates for those babies and moms that are using, so that we can help them get clean and have healthy pregnancies in the future. So the dyad part, it's the separation of the infant from the mother, the father during withdrawal, and that period impacts attachment and bonding. It's the guilt, substance misuse, and mental health issues, including trauma, that can impact attachment and bonding. It's the poor infant issues, those poor sleep patterns that we talked about, the fussy, irritable temperament. These babies can cry forever without and really having difficulty being soothed, the poor eye contact, the overreactive or underreactive to stimuli. All of that can have an impact on attachment and bonding. And attachment is a two-way street. Every individual, each mom, each dad, each family, each caregiver that comes into that baby's life must be able to read the baby's cues and each other's cues and be able to respond appropriately to those cues. And when an infant's neurobehavioral functioning is disrupted by the effects of prenatal and drug and alcohol exposure, that infant may not be able to participate in that give and take dynamic that we call that sort of dance that's required for attachment to occur. And when the caregiver does not receive that positive feedback and reinforcement from the baby, she or he may distance and feel like they're bad, or the baby. I had a mom once tell me that her 2-month-old hated her, and it was because of this dance of attunement and her feelings when the baby just wouldn't react to her that made her feel that way. And so it creates stress for both the parent and the infant, and then that cycle of stress just increases and continues going. So on the impact on the infant and parent relationship becomes this vicious cycle. You've got this dysregulated infant. This mom's negative response increases the infant's response. Mom then feels rejected and inadequate, increasing the risk for relapse and misuse. This is also true of dads. And then both mom and infant disengage, and insecure attachment is at high risk. So you can just continuously see how this vicious cycle plays out. The only one who can break this cycle, can the mom break this cycle on her own? No. Can the baby break the cycle? No. It really takes intervention from one of us, from an interventionist that can come in and very supportively helping the mama and doing it with support and love and grace to help break this cycle and get back on a healthy track. And now we're going to pause to watch a video involving mothers in the care of their substance use dependent babies.
At any one time, we may have anywhere from 10 to 15 babies in the hospital that were subjected to a substance in utero, many of whom are withdrawing or have neonatal abstinence syndrome. And typically what happens is these babies are stabilized in the neonatal intensive care unit for a day or two and then transferred to the newborn nursery, where they're then, if they have to be, they're treated with some pharmacologic form of intervention. Over the years, we've realized that there are a number of issues associated with this approach. If you have to start pharmacologic therapy, babies may spend up to 3 or 4 weeks, sometimes a month or two in the hospital while we're trying to wean them off that pharmacologic treatment, which increases the length of stay, increases costs, increases the time of separation between mother and baby, etc. The approach to the treatment of these babies should be initially non-pharmacologic. In other words, the treatment, and we've seen this recently, the standard of care should be keeping those mothers and babies together as much as possible. So there are many programs throughout this country that are using the mother as the first line of therapy. In other words, they're allowed to breastfeed, they're allowed to stay as long as they can with their babies, holding their babies, rocking their babies, much like what we have to do in the newborn nursery or in the intensive care unit using our own nurses. And if we can focus on that, many times it has been shown that we can perhaps not have to start using medications to treat these babies' withdrawal. It's really just trying to focus on keeping mothers and babies together. Even if we have to use pharmacology, it has been shown that the amount of medication that we have to use is a lot less, and that the length of stay in the hospital can be reduced significantly by using this approach, the non-pharmacologic approach. It also requires the destigmatization of substance use in pregnancy. In other words, much more of a supportive role for these mothers as they're going through this transition period, especially in the early postpartum period when this baby may have some withdrawal. It's a disease, and so, you know, smoking is an addiction. Diabetes is a disease entity, and as I was trying to say earlier, if someone misses their insulin treatment, or if they're a so-called brittle diabetic and they develop diabetic ketoacidosis, we're not going to stigmatize those people and discharge them from a clinic because they missed their insulin dose. It's in the same way, if this mom relapsed because of whatever pressure she's developed from the outside and has gone back to using more substance before, these are the people that need our help the most, that we need to bring them back to compliance. And instead of stigmatizing them and allow them to continue with this habit.
Okay. I really like how he is, I really like how the doctor is so supportive and encouraging. and helpful. I just like his demeanor is just wonderful. And I thought that you might like to see that. So in the rest of the time that we have together, I just wanted to talk about um, some effective attachment-based parenting training programs for parents with substance use disorder, as well as trauma and some of the other things that we see that can happen between moms and babies and dads and babies. And one of my very, very favorite programs, then yes, someone just said in chat, this approach sounds much more positive than psychopharmacology. I agree. So we all need to get it in our hospitals and making sure it's taking place. So Circle of Security is a wonderful program for moms, dads, babies, and yes, moms, dads, babies. Security is for the entire family, and more families, extend into our extended family. So if they're caring for the baby, then they can certainly be a part of this program. And I think we have Circle of Security. It's statewide now. Somebody just asked, how can we get a hold of it? You can call your mental health, your mental health program in your area to see who may teach it. I think there's probably also online. I'll search that for where it is in Florida and how you can contact them. We've had it at the Florida Center for quite a long time, and I'm looking at chat. I'll come back to that. And the goals of the Circle of Security are to increase the security of the attachment to the child to the parent, and yes, that's mom, that's dad, to whoever is involved in that child's life. It's increasing the parent's ability to read the child's cues. It's to increase the empathy in the parent or the child, and to decrease negative attributions of the parent regarding the child's motivations. So a lot of things that might seem like, well, this is just normal, they don't have that. Moms and dads sometimes don't normally come with these kinds of things because they were never parented themselves in that way. But it doesn't mean we can't teach them and we can't support the process of that taking place for them. And so this is just, I'm a visual person, so I love this visual of Circle of Security. It's sort of holding them in your hands and walking them and knowing what that safe haven is like and that secure base. And as they begin to feel more secure, they'll begin to venture out. And you can see the little guy on the other side of the circle. He feels secure enough that he can venture away from you for a little bit. They always come back and say, I need my safety base. And it's really for the parent to be stronger and wiser and bigger, and to realize this little tiny person needs so much help in feeling secure, in developing and in growing up. And as adults, we have the responsibility for helping in that security. And it's now they also have a program for teachers, and I'm so delighted about that, because so many of our little ones are spending time in childcare centers. And as we, all know, childcare teachers are not paid a great deal of money. And some of them are lacking in this sense of security. So the more that we can get adults trained in the Circle of Security who are surrounding the children, both in day care programs and in families, the more that child is going. And remember, safety and security is the first psychological base that forms. So it is a great program. We have had moms that have had 3 to 4 kids removed and never returned, removed permanently, termination of parental rights. And then a baby comes along and they've engaged in Circle of Security and they've been able to keep that baby. And that's just like one of the most glorious things that you can ever see. And then again, for me, if you're changing that baby's life and they're learning differently and they've got a different environment from what their parents had, you're changing every generation to come, not just that one child. So we also are promoting family-centered care for pregnant and postpartum women with substance use disorders. And family-centered treatment assures that the pregnant woman, moms, infants, families, dads for sure, receive an array of coordinated services to support them during a mother's recovery. The partner of the woman, the dad or the partner, is the most important person in helping her along in her recovery. If he's using, she's much more likely to relapse and start using again. So he needs to be a supportive person in this recovery process, and making sure in helping and supporting her in staying sober and remaining sober. And a family-centered framework involves children, partners, other family members. Often grandparents are involved in this treatment process. And it assures that all family members receive the health, care, and the community-based support that can help them thrive. And with respect, with caring, respect that they deserve, and to not be shamed or blamed. That is not anything we want to see in this kind of family-centered treatment approach. And for example, a family-centered approach may integrate the screening, the brief intervention, referral, and treatment in maternity care clinics, coupled with long-term follow-up and home visits, such as what Healthy Start and Healthy Families does, to ensure that the mom and the baby are receiving necessary resources. And at the time of birth, a family-centered inpatient approach co-locates mothers and infants after delivery as a best practice known to improve maternal and infant health outcomes. And we're really working hard to spread this family-centered approach across our state and across our nation, because the results are there. The studies show that this is the best approach, long-term, short-term and long-term, for the family, for the mom, the dad, the family, as well as for the baby. Also, we all know that supportive plans of care are now a federal mandate, and I gave a webinar here with FATA once, I think last year or the year before, on supportive plans of care. We need a plan for the baby. I've worked with our Sarasota Memorial Hospital on this, our plan of care for the baby, our plan of care for mom, and our plan of care for the dyad. There's also the plan of care for mom is the plan of care for dad as well. And the plan of care for the dyad is the dyad and the triad. It's not just moms, although moms usually have the primary responsibility at birth of caring, but it's definitely not leaving dad out. We want to be so inclusive, dad, because mom needs dad to be supportive to her and to help and to be involved. And the baby needs dad or the partner to be involved in a part of their lives. So we'll stop. Let me stop for a second here, and you can use your chat on what are 3 possible strategies that could support family-centered care. So you can just use your chat and just put in 3 possible strategies. I see somebody who just lost audio. Family team conferences, yes. That's a good one. Having intervention programs in the hospitals that follow, yes. Counseling support groups, team meetings. Individualized plans, father services, family therapy, online groups. You guys have a lot of ideas. Engaging extended families. Cecily, thank you for that, because I think we just forget about those extended family members, and they're so, so important. Peer specialists, peer support, yes. It's going so fast, I can't see it. Wraparound, yes, wraparound services for sure. Family-centered groups, teaching family activities, yes. Faith-based organizations, we should absolutely be including our faith-based community. Early intervention, yes, yes, yes. Family treatment centers, anti-stigma, all great answers. Strong natural support systems, yes. Preparental training for substance use mothers, yes. All great ideas, guys. Thank you so much for supplying those. And then what do you think from a systems perspective are the main barriers to supporting family-centered care? How are the service systems not really supporting? Missing fathers. Lack of coordination, stigma in many areas, lack of funding, stigma with mothers of SUD. Stigma, I see stigma up there so much. Lack of availability of services. Food insufficiencies. Yes, those are all important barriers. Transportation. Yes, continuity of care for sure. Education, lack of services, the uninsured. Yep, broken homes. Generalized multi-generational trauma. Language barriers, for sure. All of those are absolutely positively barriers that we have to work access to care, access to services, education. Housing, and housing's becoming more difficult in the state of Florida because you can't afford to live here. I have a mom I'm working with right now. She's living in a motel, has been living in a motel, and she is paying that motel $1,300 a month. And it's like mind blowing to me. And no kitchen. It's a microwave and a small refrigerator. But yes, so many have families in hotels. Yeah, how do you raise a family in a hotel? It's just there. Yes, we have a lot of system issues and barriers that we need to be barrier busters in any way that we possibly can, and that's part of our advocacy role, I do believe. So let's, I think we are almost to the end here. Let me page down. And then one final question. What will you do differently in your own work with the knowledge that you gained from today's presentation? Anybody? Anything you do differently? Knowledge with the families. Share the knowledge with the families. Yes, this presentation is for providers, for families, for other family members. More education, sharing with families. More probing questions, good. Educational for teens, yes. Education, support. Good. Good. I'm so happy to see all of these great answers. Trained staff, yes. Don't keep this information to yourself. Put it out to the world. Education and support with the family. You know, in that slide of the circle of security, how we train the parents to kind of hold the baby. I feel like we hold the families. I feel like that's part of my role in the work I'm doing with the staff at Children First. I'm holding the staff. And the more that I can hold them and impart security for them, the more they're able to take that and use that with their children. And helping to humility, kindness, and love. Thank you, Giovanni. That is so, yes. And sometimes it's hard for us to hold on to that when we are all sometimes tired and stressed as well, but we have to be the holder of that for them. Great answers, you guys. Thank you. Treat them like family. Yes, maintaining our barriers and our boundaries, but treating them like family and treating them with respect. Many of these families have never been treated with respect, and it's so hard for them to even know what that is, and to know that you're not going to change. That's how you're going to be with them every single time. That's the person you're not going to be punitive, critical. You're going to be holding them, and you're going to be supportive every single time you're with them. And so we know that with the right interventions and coordination of services, listen with an empathetic approach, we can change a family's trajectory to help build resilient, healthier families for generations and generations to come. So just as our summary, it's important to focus on the woman's voice and choice, address her fears and stigma, and provide evidence-based interventions. Remember, there is no safe time or safe number of drugs and substances that can be used during pregnancy. All women and all fetuses metabolize drugs and alcohol differently. And so predicting short or long-term outcomes of prenatal substance use is not possible. The risk can be high for both short-term and long-term developmental problems for the exposed fetus and can be lifelong. And supportive interventions are necessary for parent and child to negate the adverse effects and promote optimal outcomes for mom, dad, child, and relationships. And any questions? Oh, how do we get a copy? I think that Robert's going to answer that in just a few minutes. And I just want to say thank you to all who attended. I see we have 306 attendees. I'm so impressed. I hope this was worth your while of 2 hours. Thank you for being here and for being a part of this presentation today. And my word to you is go forth and spread the word and be your best selves always. Thank you.
Thank you, Ms. Shea. I have a couple of questions that came up through the chat throughout the presentation, so I'll kind of go down that list one by one and keep my eye out if anybody else has any questions. One came earlier, said, can detox cause stress on a fetus?
On a fetus, yes. Detox can cause stress on a fetus, and they will often use medications to help lower that stress. And so that the baby, and also if they're having seizures, they can use medications to help lower the stress that the baby's in. They certainly don't want to use more than what they have to, but they have used, I'm trying to think of the one in particular that's been used, but yes, they can use some medications to help that baby not be so stressed.
Got it, thank you. Another person asked in the chat, or they shared an experience, I should say, that it is a struggle sometimes for us to not be judgmental when we're working with people who are misusing substances while pregnant. How do we help those without being judgmental? How do we help those individuals?
Well, I think it's, you know, I have never worked with a pregnant woman who said, I want to harm my baby. And not ever. And I don't think there is one that would ever say, I want to harm my baby. So it's gently talking to them, you know, about having safe outcomes. Like, you know, what kind of safety do you want to see? How do you want to see your baby when your baby is born? How do you want to see your baby healthy? Help create that vision of a healthy baby for them and having successful outcomes for them. And how they want to feel as a mom with that baby. And let's see how we can get there. Let's make our plan of care right now for how you can envision yourself being the best mom you want to be. And let's walk you in how to get there. How can we help your baby have the best? And then begin to talk about some of the adverse outcomes of drug use and alcohol use during pregnancy, and how can we get you to having better outcomes for your babies. We have a wonderful program here in Sarasota called the Mothers and Infants Program with First Step, and we also have drug court. So if moms are, and as you know, nationally, women are being more criminalized for this behavior and being punished and being jailed. And in our system here, they can choose treatment, go into the Mothers and Infants Program where they're given support immediately, and they are, you know, they're given treatment immediately, and we go in and do some mother baby classes while they're in there. We've actually done a circle of security class there. So creating those kinds of environments where the pregnant mom can be with her baby during that pregnancy is one of the best outcomes we can ever wish for. So there's so many creative programs that we have around the country. but just being her ear. Somebody said before, listening, listening, listening. And yes, listening, listening, listening is one of the best things that we can do. Let her tell her story. And, you know, I say the words, I'm sorry that happened to you. Often, and in the world of trauma, we don't say what's wrong with you. We say what's happened to you. So we're using that trauma lens because many of these women have been traumatized and have never worked through their own trauma. So I hope that was a good enough answer.
Thank you. I have a couple more questions, but one I want to ask, you know, out of order that I have them because you mentioned it. Is somebody asked, are there any policies in place right now that promote the decriminalization of pregnant mothers who are misusing substances? I heard you mention that there is currently kind of this attitude of criminalization, and somebody just asked in that moment if there are any policies that are supporting decriminalization.
There are. Tennessee is actually one state that has, and I will, if that person who asked that question, if you send me an email, I will get it to you. There are several states actually that are moving in that process. Tennessee is out front, I think, right now in making sure that women who are arrested and they're pregnant are offered treatment in lieu of jail. And if they refuse treatment, then they may have a jail sentence. But they are, which, oh my God, doesn't that just make sense? Do you want to go to a treatment program so you can, you know, get free of substances and have a healthy baby? Or should we just, you know, we're just going to send you to jail so you can have your baby there? It just makes absolutely no sense on any level. And we need to have a federal law, I think, but this is probably not the political climate to do it in. But we could start in the state of Florida.
Awesome, thank you.
I might whip up a bill tomorrow.
Kind of continuing with that theme, somebody shared a personal story that I wanted to reframe as a question. You know, they shared a story about how they are in recovery and experience a lot of stigma and are working in advocacy as a peer now. And that made me want to ask the question just for all of our attendees. Outside of our professional roles, what are some ways that we can get involved in advocacy for pregnant women who are struggling with substance misuse?
Well, I think that is a really great question. I think we can do it on a local, everything, who was the politician that said everything starts local? And I think that that is true. We've made a lot of headway here in Sarasota we have a very tight community of providers, peer support people. We do a lot of training and teaching in just social groups and out in communities. And the FASD United also has a peer advocacy team. Kathy Mitchell, who is a recovered mom, has started that group. She has monthly conversations and does a lot of training on how to be a peer advocate. So there are ways, and if you want to get in touch with me, I can get you in touch with Kathy and get you into some peer training groups.
Awesome, thank you so much. I think we have two more questions. One person asked back at the video, they asked if that approach, if it increases the negative impact of withdrawal on the baby without medication intervention.
Ask me that one more time, Robert.
So going back to the video, the approach that was featured in the video, does that increase the negative impact on withdrawal on a baby without medication intervention?
No, I think the doctor actually stated that it has more of a positive outcome than using medication. And he really said it was because of the bonding that was taking place between the mom and the baby, which tells you that that bonding is physiological too, that touch, that body to body contact, hearing the mom's voice, seeing the mom's eyes, all of that impacts the brain. and can actually soothe the baby better than medication might be able to. So I think it's the best approach we're seeing, and I think there's research to support that.
Awesome. Thank you so much. I think last question I have is somebody asked in the chat, what are the what is the percentage of births in the United States with babies that have fetal alcohol syndrome?
That number is changing. There was a study done, it used to be 1 in 100 with full-blown fetal alcohol syndrome, which is at the furthest end of the spectrum. The numbers I saw the other day in the FASD spectrum is about 20 to 30 per 1,000 live births. But there's a recent study that went in and screened kids in kindergarten that found that 20% of the classroom were kids on the FASD spectrum, which is mind-blowing.
Thank you so much. I think
and there is the FASD United website if you want to find out more on fetal alcohol. We also do have a state FASD task force that is relatively newly formed. We meet monthly. If you would like to be a part of that task force, please let me know. I will sign you right up. And we have about 20 people that are joining every month, and it's been, we do now have a state strategic plan for FASD, which I'm very proud to say. And so we're gonna make headway with legislature and getting an education in all of the systems. We have miles to go before we sleep, but we're gonna get there.
Awesome. Thank you so much, Ms. Shea. One thing I want to display is we've had some people ask in the chat about resources, so I've put some of those up on the screen now. I'm also once again posting the link to the PowerPoint in the chat for those of you who are looking for these resources. I understand that on the PowerPoint you cannot click that link, but if you use the PowerPoint PDF in the chat, you can scroll to the resources slide. All of these resources are hyperlinked, so you can click on them and view those at that time. So I'm going to show those. There's a couple more on the next slide. Specifically, there's some on here for medications, pregnancy, and lactation as well. There's also a free pediatric primary care trauma course if you are interested in that. Again, those are in the slides that you can click to view the resources as well as some videos. With that, Ms. Shea, I want to thank you so much for your time today. I'm going to flip over. Please note a few business items before we conclude, everyone. I've seen a lot of requests for the presenter's contact information. You can see that there, ksheaconsulting@outlook.com. Ms. Shea has been great, and she has offered a lot of support for those of you looking for more information, or maybe you have additional questions or want to know more about getting involved. Please feel free to email Ms. Shea and follow up with her at the conclusion of this webinar. So with that, thank you again, Ms. Shea. I'd like to say to everyone here today that if you are looking for CEUs, we have put some information on the slides. You will be redirected at the end of this webinar to the FATA website to complete the evaluation. You will be prompted to sign in or register. You can register as a visitor at no cost if this is your first webinar with us. Please do ensure that your name and your email address that you provide at registration match the name and email address you provided when registering for this webinar. That is the only way to connect your attendance and your evaluation. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license, prefix, and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. Again, please remember to use the same email address and name as you did in the webinar. You will get a second opportunity to complete the evaluation through a follow-up email later this afternoon. As a reminder, the evaluation will close at midnight on Tuesday, October 31st, 2023. If you experience any difficulty logging into your account or accessing the survey, you may contact FATA's team either by filling out a contact form on our website as shown on the screen, or by sending an email to training@floridabha.org. Please ensure to send us an email if you're experiencing difficulties before the evaluation closes. As a reminder, we do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and the PowerPoint, please visit www.fata.org, navigate to the Resource Center, and click on the training library as shown on the screen. Thank you again for participating in today's webinar. I'd like to again thank Ms. Shea for all of the wonderful information and the work she put into this webinar. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Hope everyone has a great day. Reminder, as I close the webinar, your web browser will come up and ask you to be redirected to the evaluation. So please don't close out of your web browser when that pops up. Please go ahead and complete that. Have a great day, everyone, and we will see you at our next webinar.
Thanks, Robert.